Our next speaker, actually she may not know this, but very meaningful to me. One of the first places I went to with my first type 1 patient was a Facebook group, and this was maybe 7 years ago or so, maybe 6, 7, and it was type 1 grit. If you're not on the type 1 grit Facebook group, you should go there right now. Sign up, ask to be part of it. And she's actually one of the co-founders of that amazing group. Now, that amazing group has since been studied and published, as we've mentioned, in 2018 in Pediatrics to show exceptional glycemic control and amazing outcomes. So this amazing resource has helped countless of my patients. And so I want to personally say thank you. Today, we're going to have Allison Herschede. Did I get it right? Oh, I got it right. Yeah, we got a lot of tough names today. She is a registered nurse, a certified diabetes education specialist, and she co-founded and is one of the admins of Type 1 Grit. So I have to thank you personally. She has personally been living with Type 1 diabetes for your entire life, if I have that correctly, 40 years. So not only does she have clinical experience, she has personal experience, and she has co-developed one of the most amazing tools and support groups on the planet right now. So thank you for coming here.
Thank you for the introduction. I have to say I am so excited to be here today. I am starstruck. I'm so excited with all the prestigious speakers who are here today that I'm surrounded by. So I'm just starting with a little disclaimer. I am not a physician. Any changes to your diet or your diabetes management should be discussed with your healthcare provider. And I guess I don't have to cover my background, but this is my 43rd year with type 1 diabetes. In July, I'll be 43 years. I started eating low carb in 2010. After I did that, I was able to lose 55 pounds. I was able to stop 15 prescription medications I was taking at the age of 30, and I cut my insulin in half. But my blood sugars still weren't where I wanted them. In 2013, I was at almost 0 carbs, and my A1C was still at 8%. And I had heard of Dr. Bernstein, but I wasn't actually following Dr. Bernstein. I thought I was following Dr. Bernstein because I was eating low carb, but there is so much more than the low carb. It's the diabetes management protocol, the insulin dosing protocols. So in 2014, I went back to school. I got my RN, and then I proceeded to get my certified diabetes educator, and I'm now a diabetes coach / consultant for diverse diabetes. And I wrote a book called Grit Pregnancies in 2021 on type 1 diabetes and pregnancy. This has already been quoted, but this is my favorite quote from Dr. Bernstein, that diabetics are entitled to the same normal non-diabetic blood sugars as non-diabetics. So how do we normalize blood sugar? We've already talked about the therapeutic carbohydrate reduction. So we're going to reduce our carbohydrates to protein, to fibrous vegetables, nuts, seeds, dairy if we tolerate it, maybe a few berries if we tolerate it, though Dr. Bernstein would not agree with me. We test basal insulin in the fasting state, as Dr. Lerner has mentioned. We test our insulin sensitivity. We don't just use a formula or an arbitrary number. We actually test how much does 1 unit of rapid-acting insulin lower blood sugar, and how much does 1 gram of glucose raise blood sugar. We implement the use of regular insulin or Act Rapid to cover protein, or if we don't have access to regular insulin, we can use an insulin pump with extended boluses. If we don't have access to an insulin pump, we can do multiple injections of bolus insulin, of rapid-acting insulin, to cover the rise from protein. But protein does, in fact, require insulin, as has been previously mentioned. We're going to correct highs and lows precisely and to target. And using a CGM, a continuous glucose monitor, is one of the most beneficial things that completely changed my life. In this graph over here, this is one of my clients who just delivered a healthy baby that was only 6 pounds and 2 ounces. She had a spontaneous delivery. She had no complications, no issues whatsoever. And that was her average right before she delivered. She was at 94 milligrams per deciliter with a standard deviation of 21, 95% time in range. And that's in pregnancy range. So I wanted to talk today about the challenges with hormones in women with type 1 diabetes. And puberty is probably the most difficult challenge. I was told this secondhand, I don't know this for a fact, but I was told that someone went to Dr. Bernstein with a teenage girl, and he said, I cannot guarantee a teenage girl, because it is quite challenging. We have dramatically increased insulin needs. It was previously mentioned, especially during periods of growth. And we tend to see those increased insulin needs most commonly at night, often during the hours of 3 to 7 a.m., and the basal rates may need to be increased, or the basal may need to be split to give us full 24-hour coverage. Our bolus and our basal needs are going to increase during puberty. So those insulin needs, they can be as high as 2 units per kilogram. And I have seen this. I have seen this in low-carb teenagers, as someone else mentioned recently, taking over 100 units a day. Variable insulin needs. Insulin needs can change rapidly and frequently, so we therefore need adjustable insulin. We need flexible insulin. And those insulin needs are going to taper off as the puberty ends and they become adults. So some helpful tools. We're going to manage those variables. We're going to control what we can control, and that's what we put in our mouth. So therapeutic carbohydrate reduction. I highly recommend the book, Taking Charge of Your Fertility. You might think that's for someone who's trying to have a baby, but this book taught me so much. It was like the Dr. Bernstein's book of hormones. It taught me how to learn about my body and what was happening with my body and how I could adjust my insulin based on what was happening. So we want to learn the signs and symptoms of ovulation and the impending menstrual period. When I was 15 years old, my mother taught me how to gauge when ovulation was occurring, and I was like, ew, gross, Mom, why would you tell me that? But that was one of the most helpful tools that I've ever been taught. So read that book. Again, an insulin pump or a flexible basal insulin, and I do want to comment, a lot of us in the type 1 grit community are very upset that Levemir, or insulin detamir, is being discontinued in 2024. Levemir is a very flexible insulin that allows us to make rapid fire changes as insulin needs change quickly in children. And we are left with 2 options. We're left with insulin degludec or Tresiba, or insulin glargine, which is Lantus. And Tresiba, from my own experience, does not work in a woman with a menstrual cycle. It is too long acting, it is too slow acting. By the time you make a change in your insulin dose, your insulin needs have changed again. So we're left with Lantus or an insulin pump. So that's really, really unfortunate. So this is just a depiction of the normal 28-day cycle in a woman with regular cycles. In the first part of our cycle, which is called the follicular phase, this is approximately cycle day 2 until ovulation, we're going to see lower insulin needs. We might even see low blood sugars. And I like to end with this because we tend to see an increased insulin need around ovulation that lasts for maybe a day or 2. By the time you catch up with it, it's gone. And then we see our luteal phase. And during the luteal phase, we see increased insulin needs about a week before the cycle is due. And then about 3 days before the cycle is due, insulin needs really ramp up, and people will say, oh, my insulin is like water, it's not working. Then around cycle day 2, we see the drop, and we're going low again. So we really have to be able to adjust our insulin rapidly throughout the 28-day cycle. Insulin needs do not stay the same. So one of the most helpful guides for adjusting my insulin is a tracking app. I personally use one called Femometer. For teenage girls, the Clue app is very simple. A lot of people like Clue because you can actually get push notifications, and I know people who have it set to, in that 3-day period, it's going to say PMS occurring, increase your insulin. So learn the signs and symptoms, what's happening, so you can know when those insulin adjustments need to be made. It's not working. Okay. Pregnancy is my heart and soul. If I could take all pregnancy clients, that would be my dream. Blood sugar normalization during pregnancy is of utmost importance. If we want to help a healthy baby, we need normal non-diabetic blood sugars. So in pregnancy, we want fasting blood sugars of less than 95 milligrams per deciliter, and we want post-meal blood sugars of less than 120 milligrams per deciliter, because non-diabetic women run between, honestly, 60 to 120 milligrams per deciliter. And complications in pregnancy are not due to diabetes, they're due to hyperglycemia, they're due to high blood sugars. So like during puberty, we're going to be seeing frequently changing insulin needs, and we're going to be seeing a lot of insulin resistance in the 3rd trimester. And if you'd like to learn more, I've written a book called Great Pregnancies. It's available at just about all online retailers internationally. And our last part is menopause. And unfortunately, I can't comment too much on menopause because, 1, I haven't experienced it yet, and 2, there is nothing out there. I've done a deep dive on the internet and there's nothing. So I've talked to the people who have experienced it, and this is a quote from my friend Debbie Terrio, and she said, "The only predictable thing about menopause is that it's unpredictable." So our estrogen levels are declining, so we're going to see increased hepatic degradation of insulin. We're going to have weight gain, we're going to have increased adipose tissue and redistribution of adipose tissue, decreased energy expenditure because there's typically less activity, and we see an increased risk of type 2 diabetes in the general population. So hormone replacement therapy could be helpful because estrogen increases insulin sensitivity, whereas the progesterone decreases it. And we see the insulin needs tend to go up and stay up. And as you can see, Debbie is our exercise guru, and this is something that can help with insulin sensitivity is exercise, so that is definitely a tool that could be used during menopause. And of note, type 1s may have an earlier onset of menopause. The last thing I want to talk about also hits close to home, Polycystic Ovarian Syndrome. I have this myself, I have PCOS, and I personally was able to reverse PCOS with a low-carb diet and metformin. A lot of people don't know this. Close to 1 in 4 women with type 1 diabetes have polycystic ovarian syndrome. In the general population, it's around 1 in 10. And nearly 1 out of 3 type 1 diabetics have PCOS-related traits, even if they don't have a diagnosis of PCOS. It's likely due to genetic, autoimmune, and environmental factors. My mother had it. My daughter probably has it. It tends to run in families. And that increased risk tend to be missed by providers. So the helpful tools, again, we're back to the therapeutic carbohydrate reduction. If we can lower the carbohydrates, we can lower the insulin and we can lower the testosterone. So there was a meta-analysis in 2019 that showed long-term reduction of carbohydrates resulted in reduced BMI, treatment of PCOS with insulin resistance, prevention of high LDL-C, increased levels of FSH and sex hormone-binding globulin, and decreased levels of testosterone. So the analyzed data indicates that proper control of carbohydrate intake provides beneficial effects on some aspects of PCOS. And there are numerous studies showing a ketogenic diet reversing PCOS. And metformin has been found to be very helpful in decreasing insulin resistance, and I am a huge fan of metformin, even not for the blood sugar lowering benefits. It just has so many benefits. Dr. Bernstein recommends metformin, glucophage, and D-chiroinositol. Myoinositol has also been found helpful, and that's something that can be purchased over the counter. It helps with insulin signaling, and it improves the ovarian function and reduces those androgen levels. It can also help reduce lipids and blood pressure in women with PCOS. And oral contraceptives are often used to manage symptoms, and that's something else Dr. Bernstein uses. So these are some documents you might find helpful. They're going to be available in the Dropbox that everyone's going to have access to. And that's it.
Please come up to the microphone with any questions, and if we have any online questions, Pam and Doug, maybe you can just let us know.
Lester Hightower, Jacksonville, Florida. Allison, thanks for talking about Levemir. I sort of want to double down on some of your comments and tie them into some of the comments that were made earlier about insulin pumps. So the road that we're heading down with the loss of Levemir is sort of a road that is this first world problem that Corey talked about, where diabetics will lose the option of not using the technology, and that's untenable. You know, patients deserve a choice, and the way we're moving, if we lose this insulin, which is so vital to teenagers, it's vital to my son, still at 18 and a half years old, it's going to really force people down a road that we don't want to go down, which is onto this technology, which some people don't want. Not only is it expensive, it has failure modes that vials of insulin and syringes don't have. So I appreciate you pointing that out. And I'd like to ask the folks in the room to keep in mind that, you know, technology should be optional for your diabetic patients. It should not be obligatory. We should have a choice.
Thanks, Lester. And something else a lot of people aren't aware of is that during pregnancy, NPH and Levemir are the only two approved basal insulins, and NPH is a nightmare.
Thank you very much. I'm Cynthia Myers-Morrison and a nomad. Might you talk about optimal weight and well-being prior to conception and how that fits in with all that you've talked about? Thank you so much.
Normalization of blood sugars, I would say, is the most important thing prior to conception, because if we wait until we're pregnant, that can lead to a lot of issues, because that fetus is developing in those first 10 weeks of pregnancy. That's when all the organs, that's when everything's being developed. Some people don't realize they're pregnant until they're well far along. So optimizing blood sugar control is of utmost importance. And as you mentioned, weight, obviously that's something else that's a lot easier to manage outside of pregnancy.
Eric Westman, Durham, North Carolina. Some years ago, Doug, Pam, and I were invited to a conference in Jakarta. It was the Indonesia Conference on Low-Carb Diets. Tio Prasetyo introduced us to doctors who had been using keto and fasting together. It's a largely Muslim area of the world. And that's when I was first introduced to Keto Babies. I asked them, what do you mean, keto babies? So these are, you know, doctors in that part of the world. Oh, we have hundreds of keto babies. Well, we're worried that, you know, something might go wrong. And they're like, we think they develop faster than babies that are given sugar. So I was kind of shocked, and then, you know, saw your book with type 1 grit pregnancies, and I'm a lot less worried. Of course, I have one foot in academia, one foot out here at these kinds of conferences where I learn a lot, and yet unless there are research studies documented and you have good follow-up and all that, academia is not going to be very tolerant of this young, brash Dr. Westman talking about keto babies. But anyway, thank you for putting that information together, and any OB/GYN who kind of gets into it either with their own experience or because of the PCOS reversal or even, you know, for whatever reason, maybe get a grant for it. Yeah. This is an area that needs some formalization. And it kind of makes sense theoretically that everything's going to work just fine and the baby's going to be fine. I mean, I even had a lecture from a professor of obstetrics, and he at a weight loss conference basically said, I don't care what you do to the mother, we're going to be measuring the growth of the baby. And he was basically saying you can have the mom lose weight, I mean it's excess adipose weight, and as long as the baby's growing, he's not worried. So, well, that's reassuring too, but still, it would be nice to have some studies. Switching gears, tell me what happens when someone goes into type 1 grit. Because I refer, type 1, you need to go to this Facebook group, type 1 grit.
Well, you need to have read Dr. Bernstein's book, and you need to be following his plan, and you have to answer all the questions accurately. But I do want to comment on what you said previously. You're absolutely right. And the problem is no one wants to experiment on a pregnant woman because that's unethical. And all the studies we do have are on diabetic ketoacidosis or on starvation ketosis. We don't have the studies on a well-formulated, nutrient-dense ketogenic diet. So I think our only option is going to be an observational study.
Well, and that's the place to start. And not everyone's ethics are the same. If you're in charge of an IRB and you're going to say you need to have everyone in a study, IRB approved and all that. The 4 people who reversed their myocardial disease on their own, and we did a case series, we had no IRB involved. They did it on their own.
Yeah.
There was so the ethics of putting someone into something they didn't choose to do, or there's a comparison group or something like that. Yeah. So we do kind of dwell in that area of we're watching observations and getting that put together, and then will grow, hopefully, to other more formal research.
And I have 2 groups. I have the low-carb group, and I have a general mainstream type 1 pregnancy group. So we have our groups.
Hi, I'm Evelyne Bourtois from Montreal. You talked really briefly about hormones, which is a topic that you could have talked for hours and hours, right? I just want to point out, I do a lot of perimenopause, menopause, and hormone replacement therapy as part of what I do now as a doctor. And, the average in at least Canada for menopause is 51, 52 years old. But we know that perimenopause can start 7 to 10 years before menopause, right? And we know that in perimenopause, so you still have your periods because the estrogens are still sort of okay. But in perimenopause, what starts being erratic and irregular is progesterone, right? And progesterone, amongst other things, is the hormone of deep sleep and being able to sleep through the night, not waking up at 2 in the morning or 3 in the morning, 4 in the morning and all that. And it's also the hormone, by the way, of like being zen and not being irritable all the time, right? So, but just to say that in perimenopause, a lot of women don't know they are into perimenopause. They don't know they're starting to lack progesterone in an erratic way, and this has impacts on behaviors. It has impact on lifestyle. So obviously, if you're a type 1 woman and if you're going through perimenopause and you don't sleep enough anymore, this will have a tremendous impact on your blood sugar control, right? So, and amongst other things too. And I also see patients for food addiction, and it has an incredible impact to peri-ovulation and the PMS period too. So those hormones have, my point was just that those hormones have an impact on then our thoughts and our behaviors and the lifestyle habits that we have. And chief amongst those is sleep. If you don't sleep, things just don't go well in your life, including your blood sugars and including your mental health and your mental state. So that was just a comment on perimenopause.
Sounds like I can learn a lot from you.
No, I want to learn from you. Did you take students? Can I go observe for 1 week in your office? Thank you.
I'm Belinda Lenners from Boston, and I just wanted to second what Dr. Westman said about the importance of an observational study on what you do. Just because all you're up against and what's informed the guidelines to date is all observational and even off topic, right? It's observational in DKA and in poorly controlled diabetes. So any observational study that you would do would increase the quality of the existing research on the topic and could potentially get the ball rolling and even convince people that an interventional approach might be warranted as a second step.
Absolutely.
Loved your talk.
This will be the last question. Sorry to interrupt. Then we'll take a little break. So go ahead.
Okay. Karen Miller from Omaha, and this kind of follows that. So I'm a family physician, and I have women I've gotten, not personally pregnant, but gotten pregnant because they ate under 50 carbs. And then they get to their OB, and then their OB sends them to maternal fetal medicine, and we've arbitrarily decided 100 grams is safe. I'm like, okay. The women are terrified. How am I going to follow what my family doctor says if my specialist tells me there's untold harms if I go under 100 carbs? Right. How do you navigate that? Because getting them to switch gynecologists isn't always an option. They're terrified. You know, there's not a lot of studies to support what we do.
I just tell people to do their own research, and I tell them my stories and my anecdotes. That's about all I have right now. But this is something I come across so frequently. I have people who are doing so amazingly well. I just had one last week come to me and she says, no, but my doctor says that low carb is not allowed during pregnancy. And I said, I can't tell you to go against your doctor, but this is something you're going to have to decide for yourself. And that's what I did personally. My last pregnancy was low carb, and I just did my research and decided this is working for me, so I'm going to continue on. And you're absolutely right. My doctor said, you want 100 grams, insisted, please eat at least just 100 grams.